Welcome to TraumaCast. It's like a podcast, but about trauma. Listen and learn from our team about current trends, new research, and continuing performance improvement efforts. This education is eligible for CNEs. Successful completion includes watching or listening to the entire session and completion of the attestation and evaluation. The link for the evaluation and attestation is located at the end of this video. We hope you enjoy. Please let us know what you think. Welcome back to TraumaCast. Today we have the usual suspects, Jen, Liz, and myself. And today we are going to be discussing the topic of neuro assessments in the ER, when to do them, how to do them, why we do them, and why we need to document them. So as everyone who is watching this knows, the ER is seeing unprecedented levels of people in the ER, waiting in the ER, waiting in the hallways, and waiting in the other hallways. And during this time, we have to really stay on our game and, keep on reassessing all of the patients. And I know that we have the ICU coming down and rounding on the patients down there as well. But this is specifically, we're going to talk about our neuro patients. So Jen and Liz, are we seeing neuro patients being boarded in the ER? Or is that something that happens? How long are they there? And let's talk about that a little bit.
Yeah, that's something that's actually not new. We see patients a lot of times, kids who come in and have a small subdural hematoma or a small epidural hematoma, that neurosurgeries, they don't meet the criteria for going to the OR, but because these hematomas can continue to bleed for several hours, they want them in the ICU for Q1-hour neuro checks. And so over years, we've definitely had these kids that stayed in the, had an ICU bed, but because they're not critical, they keep getting bumped by other kids. And so probably
this isn't because we're busy. This is just an ongoing thing.
Yeah, definitely. Their average stay in the ER waiting for a bed for a non-critical or an observation ICU kid, it used to be about 6 hours because of the acuity in the emergency department and the acuity and shortness of ICU beds. We're seeing that number go even longer. So kids are waiting, 8 to 10 hours and longer even right now for those beds. And so again, these are kids with small epidural, small subdural hematomas that are being admitted to the ICU because they truly need Q-hour checks in order to make sure that their bleed is not growing, if that makes sense.
So when you say checks, does that mean that the family is letting the nurse know if anything happens on an hourly basis, or does the nurse go by and say like, hey, mom or dad, like, how's Junior doing? Like, when you say checks, is that just like a brief, like, peek your head in the door and being like, everybody good? We're good? Okay. Or like, what does that mean?
Well, it would make everybody's life easier if that was the definition, especially right now. However, unfortunately, no. And the answer I have is not the popular answer, especially in the middle of the night. So the answer really is every hour we need to be doing a comprehensive neuro check, which means you should be waking the child up. You should be, in perfect world, you get a GCS score. And even more important than a GCS score is what are their pupils doing? Because remember, that sign of that expanding hematoma, you'll see it in the GCS, but you're really going to see it when they get into trouble with pupillar reaction. And so if one pupil is blown or if your pupils aren't reacting, that is going to be a key indicator for what you're seeing. Additionally, now the easier part of that is, the other part is the vital signs that go with it. So looking at your heart rate, definitely your heart rate. As we know, bradycardia is one of those other key signs that when you're starting to get into neurocompromise, you're going to see a problem. So I think those three together, GCS, heart rate, and pupillary response.
And just to remember too, when there is a head bleed, there's irritation. And so these kids are also at risk for seizures. So again, just making sure all of your safety equipment is in there, quick safety check at the same time too, but also know that that's a possibility.
So so a neuro assessment is going in, seeing if the kid's responsive. So whether they are just alert, so sitting up in bed, coloring, watching a movie, talking to their parents. If they're asleep, see if they like arouse to like a verbal stimulus, a painful stimulus, or if they're unresponsive, hopefully not. Getting a GCS if possible, and checking their pupils. And so if a kiddo needs neuro checks Q1 hour, does that mean what you were saying earlier, Jen, that they need their vital signs checked every hour as well?
At least every 2 hours, every hour. You're already in there every hour. And so my theory is if I'm already going in, I might as well get the whole kit and caboodle. But neuro checks every hour, vital signs every 1 to 2.
So for documentation purposes for the emergency department, does that just go under RN reassessment, or do they document an iView?
iView.
Okay, so this is like out of the normal flow. So we have to remember to go into iView to document this neuro assessment.
Yes.
And Liz, how long should it take to like check pupils, check responsiveness? What was the third thing? Now my brain's like level of responsibility, pupils and GCS, GCS and a heart rate. Dear God. How long should that really take?
This really shouldn't be too long. So you have the patient on the monitor, right? So if you're doing Q1 hour neuro checks, have the patient on the monitor. You can eyeball the heart rate, make sure you have a good form as you're walking into the room, nudge the child or have the parent kind of help you, and then just grab your light and look for the pupils. So it shouldn't take very long at all. Obviously, it'll be a little bit longer if there is a concern, if there is a neurostatus change, but it really should be a pretty quick assessment.
So if there is a change, what should a nurse do?
100% alert the ED attending. So you'll get your provider to the bedside, and then go from there. Do another assessment, plus or minus. Call the neuro team, the neurosurgery team, etc.
Okay.
And probably not be surprised if they order a repeat head CT. Now, these kids will get a repeat head CT usually around hour 6 to hour 8 anyway, to look to make sure that hematoma is not expanding, but it might expedite that head CT to happen. Okay.
So obviously we know that an epidural is an emergency, or any type of head bleed, that's an emergency. And but it's like a stable emergency, which is why it's easy for them to get bumped if there is a sicker child that needs to go to the ICU. But they're still, they need that close eye, which is why we need to do this every hour.
Yeah.
Go ahead.
Sorry, I think you have to remember that we look at a lot of, when you think epidural, subdural, you think, oh my gosh, they have to go to the OR, they need a cranie. However, the majority of epidural subdurals we see are very small. And because the cranium is that hard shell and there's not enough extra space, a lot of our kids with these bleeds are going to self-tamponade, especially the epidurals. They're going to self-tamponade. And a young child with an epidural doesn't have enough arterial pressure to sometimes cause a big bleed. And so that's why we have these kids that are on the bubble or that are stable enough to kind of watch. So this is a pretty good subset of TBIs that come in.
But they can be tricky and they can change on a dime, which is why that hourly assessment is imperative.
We had a patient within the last 6 months, well, maybe a year, that did change on a dime. And it was through good neuro assessment that it was caught and the patient did go to the OR and successfully was treated.
No, well, then go ER, woohoo, especially within the last year, because it's been crazy. So going back to like why we know that it's important, we know we need to do it, we know we need to document it. Jen, and Liz, like how are we at that? Like, what's our compliance? Like, if we like, do you have a percentage? Do you track this? And like, can you explain how that is tracked and like what we're doing and
So we track that. So we have a database in which we track all of our trauma patients. And so Liz and I look at every patient that comes in with a subdural epidural who have admission orders to the PICU. We identify those, we look at the time they spent in the ED. And if it's greater than a couple hours, we go to IVU and we look at all the IVU and any assessment data there is to see how often these assessments are made. And that way we can look at a percentage of these kids to see how many are being compliant with the Q1 neuro checks and vital signs. We've been looking at this metric for about 2 years.
Oh, wow, that's a long time.
Yeah, in FY22 that ended on June 30th, our compliance was only about 25%, which was kind of an all-time low. And I attribute that all-time low to a couple of different things. One being just the craziness of the ER, and as hard as people are trying to do everything, I do think people are probably doing some of these assessments. I just don't think they always get documented because they're just trying to keep their head above water. But I also think that we're seeing some of this. There's been a huge turnover and a lot of new people starting in a time of high acuity. And so I think you do lose a little bit, which is obviously why we're talking about this. So we have a lot of room to improve. I will give a kudos out though. There was a kid this past week that fit the scenario beautifully, and I went to the charts and I don't remember who the nurse was because I'd shoot out a kudos to that person, but whoever it was, they did a beautiful job of doing
that's
all of
awesome.
this. Yes.
So let me ask you this. How does a nurse know, and is there an order put in that says Q1 hour neuro checks? Because yes, we have extremely capable nurses in the ER, but if an order isn't there, like, how does that work? Like, is an order put in? Like, does the ER doc put it in? Does surgery put it in? Does neurosurgery put it in? Like, or is it put in at all?
So that's one of the things that Dr. Quinn and I identified about 2 months ago. We were looking at the data together because I was showing him FY22 and the fact that it was so incredibly low. And so he and I looked at orders and found that you would have both the trauma team and neurosurgery recommending these Q1 hour checks. And that was the reason we were going to get admitted. However, they weren't being included in the order set. And so I worked with Dr. Brown and it was taken to the provider faculty meeting that these kids, when they go from the code room to the ED to wait for that bed, they should have ETU orders started, and within that ETU order set, the docs now need to click on the option for Q1 hour vital signs and Q1 hour neuro checks. And so we're now looking at that also, and I don't have a rate of compliance with that because that's a new thing we've just started tracking.
Yeah, and that's huge because if the recs are written in the progress note, that is absolutely 100% not in the flow of an ER nurse to read a progress note and like, or a consult note. Those consult notes often go in way after the fact.
Yep.
Mhm.
Yep.
So it's like everybody agrees that somebody needs it like Q1 hour neuro check, but there's no order. So I'm really glad to hear that but that is going to change. I think that really may be like a huge push in getting this accomplished. That it's just that like visual reminder that like pops up on the screen like, hey, we need a neuro check, rather than saying, I have 9 patients. This one has this specific thing. This one has this specific thing, but having that on there. So when you do your reviews, that you see that.
Yeah. And I would extend to the nurses who are watching this that, from our end, we are looking at this compliance for the physicians to put this order in. But on your end, as the care provider in the emergency department, if you do have a patient with a subdural and epidural hematoma waiting for an ICU bed, and you don't see that order and you notice that, say something to your ED provider, because real-time feedback is much better than the feedback I can give them or Liz can give them 24 to 48 hours later. So I recognize that things are so busy and you may not catch it, but if we can kind of work together from both angles.
Yeah, no, I think that is that's really going to help. I mean, and that is a system fix and a visual reminder rather than just saying, okay, so just remember for this special subset of patients, we need to make sure that we get these neuro checks because when you're managing like a lot of things, it's helpful to have that reminder.
Definitely.
Liz, you're working on a project with closed head injuries too, right? Like not just about neuro checks, but like closed head injuries overall.
Yeah, absolutely. So we took a look at all of our TBI patients, and we have so many different buckets. We have the non-operative traumatic brain injury that that subset of patients we're talking about right here that don't need operative intervention. Again, Jen mentioned that that's the majority of these patients, but we also know that there's a small percentage of these patients who actually need to go to the OR, and they need to go there emergently. So these are patients that come through the trauma bay. They have an expanding brain bleed, and again, needs to go to the operating room like immediately, basically to save the child's life. So we thought that that would actually be a good place to start in terms of identifying priorities in the code room to get these patients as quickly as possible to the operating room. So we came up with a list of tasks, and we call this OR First. So the OR First initiative involves 5 steps. Number 1, and this is again, the critical patient in the trauma bay, we notify neurosurgery. The team notifies the OR, the hall monitor, and the OR charge nurse. Number 3, we optimize oxygenation. So we make sure that the patient is intubated, appropriately oxygenated. We obtain Coags and order blood, and then we expedite the head CT. So we're really hoping to get that point across, that those are the 5 critical steps to get those patients who need to go to the operating room emergently to address their intracranial hemorrhage.
Oh, wow. So, what's interesting is these are for head injured patients, and it's the 5 most important things. And that really drives home the fact that a kid with increasing cranial pressure doesn't necessarily need medications to decrease that ICP. They need a neurosurgeon, and they need an operating room.
Yeah.
So it's like that really focuses the team on like really what's important. Like, okay, get neurosurgery to evaluate, get the head CT, and get out.
Yeah.
You speak to that 3%. I think you're talking about the 3% saline that we love to give those kids who
and mannitol.
Yeah, and who are neurocompromised. And I do think it's important because people do get very fixated on that. And a couple things to say on it. First of all, at Children's National, we have a national and international expert in the care of TBI patients with Dr. Bell in the critical care. And through his research, which is extensive, it has shown that the use of 3% saline in patients without ICPs actually can delay care and cause more harm than good, because it delays us getting intubated, it delays us getting to CT. The reason we need that CT is so the neurosurgeons know what they're dealing with. And so it's because of that we put in the guideline in to minimize the amount of 3% we're taking. It's not that we care if they're getting it or not. We just don't want it to interfere with those steps that Liz has talked about.
And only give it under certain circumstances, which are that are very clearly outlined in the guideline. So we're not saying don't ever give it. We're saying give it under these specific circumstances, correct?
Yeah, and those circumstances would be a GCS of 3 and a blown
pupil. Can't get lower than 3.
No.
3 is the lowest. 1, 2, 3. You get 3 points just for showing up.
My table has a GCS of 3. Yes.
That is my cat.
Yeah. No, theirs is probably higher.
Yeah, this is true. They're both at 15. That they tell me about their feelings.
Yeah, I'm sure they do. So a GCS of 3, so a totally obtunded child. They are not responding to anything. And then you also have a blown pupil or pupils. Other than that, when we track this also, we look to see, are we compliant? Are we wasting time? And there's been times where we've chosen to give 3% before we've intubated. Well, now we are compromising oxygenation, which can kill brain cells. And so it's really, like Liz said, it's all about getting these kids to CT scan, seeing exactly what we're dealing with, so we know who needs to go to the OR and how quickly we need to get there.
I like the name of it too. Because it really gets people on the do what?
Liz came up with that.
Yeah, it's a good name. It's like OR first. And it's like, oh, wait, we should go to the OR first? Yes, actually, we should. If we have a problem, we should go to the OR.
You know, we've had people ask though, why are we bothering going to CT? We have a kid with a GCS of 3. Why do we go to CT? Why aren't we just taking these kids up? Well, I think the short answer to that is neurosurgery needs to see exactly what they're dealing with. If it's an epidural or subdural that's making our patients obtunded and emergently needing care, there's something a neurosurgeon can do in the operating room to evacuate that. However, if it's a child with an ischemic or anoxic injury, that's not something a scalpel and a surgeon can fix. And
It's
so,
not necessarily a surgical fix.
yeah. So that's why the CT is a really important piece of the puzzle.
Well, and they need to know where to go.
Well, yeah, that too.
I mean, I feel like I would want to know. I would want my surgeon.
You
to
would
know.
want a roadmap.
Like, is it here or here? Not so much here. But here.
You know, those neurosurgeons, they just want so much information.
I know. It's funny the information that they want. So this OR first, this is initiative that is mainly focused on the team that stands behind the black line.
Yes, absolutely. Making those calls to the operating room, making sure that, you know, blood has been ordered and blood is on its way. Absolutely. And again, that the critical players, you know, again, in the operating room, the neurosurgeons, everyone is on the same page and involved.
And you mentioned Coags. Could we talk a little bit of like why it's important to have Coags in a patient that may need to go to the OR?
Go ahead, please.
Absolutely. Well, as we know, so Coags and ordering blood as well. Obviously, this is a bleeding trauma patient, so we need to know, you know, if anything needs to be fixed. If we have, you know, an INR that's quite high, we just need to know, you know, the degree of coagulopathy, basically.
So can neurosurgery still do their stuff if a patient's in DIC?
Emergently, probably, but they
Yeah.
really want to know what the coags are because
They need to know. They want to
If-
know if they're opening up like Niagara Falls.
right,
or-
because if their INR is really high, they're going to pump these kids full of plasma and platelets and cryo as they're prepping, so they can work on reducing that coagulopathy. So it really helps that care before they do the incision. It makes us know what to give.
Yeah, that sounds
Yeah.
like a really important lab. Do you have to get Coags? So say we have a trauma patient that has a bleed that needs to go to the OR, but also you know, has like a pelvic fracture that was bleeding a lot. And we had to give blood in the code room. Do you have to get Coags before you give the blood in order for them to be accurate, or does it change? Would giving the blood like mess up the levels, like pre-transfusion Coags or post, or do you do both? I feel like I just asked like 4 questions at once.
You did, and they're hard. You know, that's a difficult question, because in a perfect world, we would obviously say, yes, you want a baseline, you want to know exactly what's happening. But we've all been in that code room, and sometimes you know how incredibly hard it is to get labs. And so I think at the end of the day, I wouldn't stop or I wouldn't hold a blood transfusion because I don't have my Coags yet. I would say, you know what, start the blood, get the Coags. It is what it is. I
And
wouldn't
especially
think too hard
that
about
tube
it.
is bigger. Like that tube, you can't put that in a microtainer. It has to be in the bigger one. So
Yeah. I would say the other thing we talked about, Cindy, you asked about the decision for OR first is a lot of behind the line decision. There is one in front of the line thing that has slowed up our teams with this. And that is IV access. And I know we've talked about this in other educational opportunities, that, you know what, get that one IV access, whether it's your IO, your IV. But if we're needing to get to the CT scanner, as long as we have one working access, let's just go. Because
what about Coags and labs? Now that we know how important that is, like what's more important, getting the Coags or getting the CT?
Well, you can get Coags. You have, if it's a trauma center attending, you have a critical care doctor down there, and they can do a quick arc stick with using a butterfly. And so you definitely need to have those Coags. And then we need to go to CT, but I wouldn't have 3 or 4 nurses standing around the bed, each trying to poke a vein and not being successful. find your person who can stick that artery and get them and go. That's
And,
going to be your best coags too, because if you try to get a vein and it's trickling out, a lot of times your coags are kind of useless anyway.
Interesting. So as the charge nurse in the code room, they are the ones that really should be kind of like looking at everybody in the code room, seeing what they're doing and keeping everyone on task. And if they notice that we've been in the code room for a couple minutes and everybody's still focusing on IV, would it be their job to be like, hey guys, maybe we should move to the scanner now? Or what do you think?
Absolutely. I think, again, that charge nurse is behind that black line. That is maintaining situational awareness. 100%. I think it's fine, absolutely fine to keep the team on task.
Okay. All right. Well, I think this has been a helpful discussion about all things neuro. To wrap us up, ask my famous question. Jen, what's the most important thing you want people to remember about this TraumaCast? Care of the neuro patient.
Can I do two, because we talked about two different buckets?
Well, you can say one, then Liz gets another one, then you will come back to you, because I don't want you to take Liz's, because then she'll be mad.
Fair.
And then
Okay,
I'll
fair.
close.
I'm gonna say that for those kids who are boarding in the ICU or boarding in the ER waiting for an ICU bed, it's hard to stress too much the importance of that neuro check. 90% of those kids are going to be just fine, but we just never want to miss the child that has an expanding hematoma. And we had an opportunity to find it early and save brain cells, and we missed it. So the importance of the Q1 hour neuro check.
Okay, Liz.
I'm going to plug OR first again. So remember those 5 crucial steps for the patient who must go to the operating room emergently for head trauma. Notify neurosurgery, notify the OR, optimize oxygenation, obtain coags, order blood, and expedite CT.
Okay. And Jen?
Within Liz's 5, because I knew she'd want that one.
I was like, you gotta let Liz do her thing. That's why I was like, you can do 2, but you have to let Liz talk first.
I knew she'd want that one. I think within Liz's 5, when we talk about optimize oxygenation, we need to do optimize oxygenation comes way before give 3% saline.
Got it.
Mm-hmm.
And then what I want everybody to remember is that you're appreciated, and working in the ER right now is tough. Working in the ICU right now is tough. Working in a hospital right now is tough. And I don't want everything to, I don't want people to feel like it's always coming back to nursing and now we're asking for something that's not even ordered to be done. These things, we have our PI database, and we, like, our trauma department, like, our goal is to make sure that we provide the best care for the patients. And we know that every single person that comes to work is also trying to do the same thing. And we are constantly working on system fixes and, not just death by education, but like things that will, help trigger memories and giving resources and all of that. So with that, I want everybody to be encouraged and know that we appreciate you. And if you think of a system fix that would help with people remembering to do neurostatus checks every hour, like, let us know. Like, we're pretty open and down to try pretty much anything within reason. But yeah, thank you. And my other than that, my last parting thought is, if you have a child that has a massive bleed, they need a neurosurgeon. So we should focus on that. So that's one of my 1 of 5 for Liz too.
I have
All right.
one more thing.
Oh,
Cindy, do you want to speak about the videos? So if I have a question about how to assess GCS in a pediatric patient, what should I do?
ooh, I thank you for asking that. So if you haven't seen it, shameless plug, we did make a video about how to assess GCS in an infant, a child, and an adolescent patient. It is located on YouTube. So under our trauma and burn education, where you have even where you found TraumaCast, if you look through the different channels on, or not, the different playlists on our channel, it'll say surgical resident education videos, and it's listed on there. Not only do we have a video, and you'll notice we have famous children in these videos. I'm not going to tell you who they are, so you go and watch the video so you can see these famous kids in these videos. And so we have that one, and then we also have examples of not only how to do it, but we have a separate video with like full examples of like normal exams and abnormal exams, with some great videos showing like decerebrate and decorticate posturing, and really how to elicit like a really good pain response.
Yeah, the videos are also on the trauma app. If you go under resident orientation, you can get to the GCS videos.
Oh, and
We've linked in.
if you haven't heard about the trauma app, or if you don't have the trauma app, Jen, why don't you explain to people how to get this app?
If you don't have the trauma app, you need
Get
the
it.
trauma app, because it is going to be replacing, or pretty much has replaced, our paper trauma manual. It has all kinds of references on it. Whether independent what kind of phone you are, you can either go to the Apple Store or Google Play and search CN trauma, so Children's National Trauma, and it should pop up.
Is there a space between, so it's CN space trauma or CN trauma, one word?
You can find it either way.
Oh, okay. Okay.
So you can go to CN trauma, you will open that app, and it will require you to register. You will not be able to see the contents of that app until your registration is approved. I get an email and I'm the one who approves it. And if you use
the approver.
I'm the approver. As long as I know you work at Children's National, you will get approved, I promise. The reason we have to have that approval is because it's an internal app only. I don't want to be sharing this with the outside world. And I don't care that the outside world sees everything we do, but there's lots of phone numbers in this, like mine.
And
Dr.
mine.
Yeah,
And Liz.
yeah. You have the cell phone number of every surgeon if you have this app. So I'm trying to respect and keep that all internal. So usually I will, within 6 to 12 hours. I mean, if you do it at 3 a.m, I'm obviously not up. But the minute I see the email, I will approve it. It has all kinds of resources that you could use for taking care of the trauma patient, from different phone numbers to what the guidelines are, to what the trauma activation criteria is,
The
to
GCS
the
videos.
GCS videos. There's we linked into the easy TBSA videos. I mean, or the after the burn videos. I mean, it's everything we can possibly pull into this app we have. And so it really can help you if you have any questions at all with how do I take care of a trauma patient. Your answers hopefully are just at your fingertips. So if you ever have trouble finding the app, you can't find it on the Google Play or Apple, shoot me an email, give me a call. We'll help you find it.
All right. Well, that has a lot more information than I think any of us thought we were going to give out today. All right, guys, thanks for listening.
Bye.